Okay, learning plan 9 is endocrine medications. We're going to start off with diabetes. There are two hormones related to diabetes, insulin and glucagon. Insulin is secreted by the beta cells in the island of Langerhans. Glucagon is secreted by the alpha cells. And they work together. When there is a lot of sugar in your blood, the beta cells pump out insulin to drop the sugar levels. When your sugar levels drop too low, the glucagon is pumped out, telling the liver to release more sugar. And it's a well-balanced system when it all works together. So insulin promotes the dropping of blood sugar. It transports glucose across the cell membrane. Glucagon helps raise blood sugar by converting glycogen into glucose, and it stimulates the breakdown of fat and the breakdown of protein. So diabetes is a complex disorder of carbohydrate, fat, and protein metabolism caused by a lack of or inefficient use of insulin in the body. And the ABCs of diabetes: A is for the A1C test, B is for blood pressure, C is cholesterol. We need to manage all of those to promote greatest health. The A1C, or glycosylated hemoglobin, very important to control this. This shows long-term effects of the blood, a 90-day average. Normal ranges are 4 to 7%. Poor diabetic control is more than 8%. Testing usually is 3 or 4 times a year. Blood glucose testing, or BGT testing, the finger stick, that is for spot checking. Hemoglobin A1C, it looks at a big picture, the long view. One touch tells you right then and there what's the blood sugar. We're looking for 70 to 99. That's excellent. That's great. 100 to 125 is prediabetes. And if you have a fasting blood sugar of more than 126 twice, that's considered diabetes. Monitoring your A1C is important for long-term control. It is not needed for day-to-day insulin doses. Not at all. That is the BGT. We always set individualized glycemic goals. We want to make sure that we set rational goals. If a person is much older or has limited life expectancy, we may allow much higher A1Cs because, again, big picture, we look at what that person needs. Type 1 is an autoimmune destruction of beta cells in the pancreas. The pancreas produces no insulin. You must have exogenous insulin. Exogenous meaning from outside the body. It requires insulin therapy. 5 to 10% of all diabetics are type 1. Type 2 is multifactorial. There are genetic components, but there are also other components. The pancreas produces some insulin. May not be enough. You may need some exogenous insulin, but your body does produce some endogenous insulin. You're much less likely to develop ketosis with type 2 diabetes. And most type 2 diabetics require oral control, oral hypoglycemic agents. Risk factors for type 2: an overweight adult who has a BMI greater than 25 with one or more of the following. So family history, race or ethnicity, history of gestational diabetes, history of vascular disease. Those are all uncontrollable. You either have them, they come to you uncontrolled. But hypertension, abnormal lipid levels, and inactive lifestyle are controllable. So we want to control what we can. So what's the best way of treating diabetes? Well, type 1, insulin. That's not just the best way. That's the only way. You must use insulin for type 1 diabetics. Type 2 diabetics always start with biguanides. That is the best way of treating type 2 diabetics first, biguanides. Let's look at the symptoms of hyper and hypoglycemia. Hyperglycemia, blood sugar is over 126, very thirsty, frequent urinations because you're drinking so much liquid, dry, itchy skin, hunger, blurred vision, drowsiness, and nausea. If you're seeing those in your patient and they're diabetic, you might want to check a blood sugar. Hypoglycemia, less than 70, shaking, fast heartbeat, sweating, anxious, dizziness, hunger, impaired vision, weakness and fatigue, headache, and very irritable. Some of these symptoms are masked by other conditions. So if you see somebody who has a fast heartbeat and they're sweating and they're anxious and they're dizzy, it might be hypoglycemia. It might be caused by beta blockers. So you always get a good history, a complete assessment before you jump to any conclusions. If we're treating for hypoglycemia, blood sugar under 70, if they're conscious and able to swallow, we want to give them carbohydrates, fast-acting carbohydrates, simple carbohydrates, juice, crackers, honey, sugar, glucose tablets, anything that they can get in there, and your body can quickly absorb and swallow. If they're unconscious and unable to swallow, you will not give them anything by mouth. You give them glucagon injections, IV, IM, or sub-Q, and that will quickly tell the liver to start pumping out sugar. Or you can give sugar directly. You can give IV glucose 50% glucose, and that will rapidly bring their sugar up. You'll want to recheck their blood sugar in either one of these situations about 15 minutes later and then 30 minutes later to make sure that we haven't made the blood sugar rise too much. So insulin therapy is usually given subcutaneous. You can never give it orally. Your body would simply break it down because it's a protein. Only Novolog and regular insulin can be given IV. Insulin transports glucose across the cell walls. Alcohol intake will affect insulin and your BGTs. So there's many types of insulin. There's rapid acting, short acting, intermediate, and long acting. There are also insulins that are pre-mixed, the classic 70-30, and you can do sliding scale, which is you check a blood sugar and you give more or less based on what reading you get. Now, if your person is NPO, nothing by mouth, and still has orders for a standard standalone dose of insulin, what should you do? You probably want to call the doctor and confirm what they want. Every type of insulin, from rapid to regular to NPH to glargine, they all have different peaks and durations. Remember, we talked about onset, peak, and duration. Onset is when something starts working. Peak is when it has its maximum effect, and duration is how long it's going to work. So make sure you understand that each of these has a different onset, peak, and duration. The reason that's important is it will tell you when you need that person to eat, because if it peaks very fast and drops, you're going to have to make sure you check again because their sugars will start rising quicker. You might be giving a basal insulin and basal plus. Basal is long-acting insulin that suppresses hepatic glucose production for a long period of time. You may be doing basal plus, which is that basal dose plus more as needed based on blood sugar readings. If you give a mixed dose, always make sure you drop clear before cloudy. Always clear before cloudy. There are insulins that can be mixed together. There are insulins that cannot. Lantus can never be mixed with anything. And you do not mix a combination insulin, that's 70-30, with anything else. Always be very careful mixing insulins. Insulin pens or insulin vials are inexpensive to use. They're very inexpensive, but they can have some major difficulties, especially if you have impaired vision or have difficult hand-eye coordination. It can be very difficult to drop the correct amount of insulin into those small syringes, but it's very inexpensive and it's very commonly used. Insulin pens are very convenient. It's very easy to dial up the amount of insulin you need. It's discreet. You just pull up your shirt and inject it into your abdomen or into your arm, but it's quite expensive. Insulin pumps provide continuous glucose control. It gives a continuous infusion of insulin, just a little bit, all the time. It also can be used as bolus dosing. If you eat something with a lot of sugar, you can give yourself a short burst of insulin. It decreases long-term complications. It's the most expensive. For insulin pens and insulin syringes, you want to use the same area of the skin in slightly different positions. If you're giving insulin into your abdomen, use the left side of your abdomen in rotating spots until your entire abdomen is used up, and then switch to your other side. The reason for that is your body gets used to drawing up insulin at a specific rate. Abdomen fat may draw it up at one rate. Arm fat may draw it up at a slightly faster or slightly slower rate. So use the same spot whenever possible. Sulfonylureas can drop blood sugars and cause hypoglycemia. These are oral anti-diabetic agents. So sulfonylureas can cause hypoglycememia. Biguanides were the first oral class used. The key reason to use is these decrease glucose production from the liver. They decrease glucose absorption in the gut, and they improve insulin sensitivity. So they decrease production, decrease absorption, and improve insulin sensitivity to the cells. That's why biguanides are the first and best choice for type 2 diabetics. However, this can cause renal failure. So when using with contrast media, if a person's going in for a CT scan, they must hold the glucophage or the biguanides for 48 hours before using the contrast. There are other oral anti-diabetics like sulfonylureas I mentioned, glinides, the glitazones. These increase the risk of heart failure. They decrease insulin resistance, which is really good, so that when your body is still putting out insulin, it can be used. But it can cause peripheral edema greatly, which puts you at risk for heart failure. And remember, if you had heart failure, you notice edema and peripheral edema. You might notice crackles in the lungs. We could also use incretin mimetics. This is subcutaneous injection. It is not insulin. It enhances insulin secretion. It also suppresses excessive glucagon secretion. And it increases satiety, which helps modulate appetites. You do not give this with insulin. This is not used instead before you need insulin injections. Now, things that affect diabetic treatment: illnesses. If you're not eating or eating too much, that will affect it. Infections, vomiting, anorexia. And remember, anorexia is not that classic anorexia nervosa. When we talk anorexia here, we're talking lack of appetite and stress. So let's look at the hypothalamus and the pituitary gland. Hypothalamus is in the brain. The pituitary gland is the master gland which controls all other glands in the body. And the gland that we're going to talk about mostly right now is the thyroid gland. Thyroid's in the throat. The chief function of this gland is to maintain a metabolic rate to meet the needs of the body. It does that by secreting three chemicals: T3, triiodothyronine, T4, thyroxine, and calcitonin. These hormones are made by iodides in the food and water, and they're stored in the thyroid until needed. When you're looking at thyroid hormones, think metabolism, lipid and carbohydrate metabolism, growth and development, heat production, reproduction, and cardiac and central nervous systems. The thyroid feedback mechanism is actually quite simple. The hypothalamus tells the pituitary to pump out thyroid-releasing hormone. That goes to the thyroid, hypothalamus releases the thyroid-releasing hormone. That goes to the pituitary gland. Pituitary spits out thyroid-stimulating hormone, or TSH. TSH goes to the thyroid and says, start pumping out T3, T4. When enough T3, T4 reaches the hypothalamus, it says, oh, we no longer need to put out any more thyroid-releasing hormone, and so the pituitary stops putting out TSH, and eventually the thyroid says, oh, we don't have any TSH, we don't have to put out any more T3, T4. When the T3, T4 levels drop in the blood, the cycle starts all over. That's when everything works right. We have problems when one or two of the areas break down. For diagnostic testing, we test TSH levels, T3 and T4. Those are the main tests for thyroid. The T3 and T4, the TSH and T4 are used to monitor the therapeutic effects of the levothyroxine. I want to make something really clear though. TSH and T3, T4. If you have too much TSH, you are hypothyroid. When you have too much T3, T4, you're hyperthyroid. Now, when you're hyperthyroid, your thyroid is putting out too much T3, T4. And that most common is called Graves' disease. It causes bulging eyes, fever, and tachycardia are major problems, as well as disturbed sleep pattern. It causes insomnia. In a severe situation, you can have a thyroid storm, which is an extreme hyperthyroid state, fever, tachycardia, palpitations, congestive heart failure, CNS disturbances. We're going to treat this with oxygen. We're going to cause hypothermia. We're going to pack the body in ice. We want to bring the temperature down. We might give digitalis to slow the heart. Remember digitalis from the cardiac medications. We might give diuretics, acetaminophen, antithyroid medication to try and stop the medication, stop the thyroid from working. Hyperthyroidism. You are very skinny, but you're eating all the time. You may have bulging eyes, diarrhea, rapid heart rate, and you're profusely sweating. You have no heat tolerance. Now, the medications we give this, antithyroid medications, are used to reduce the amount of thyroid that is functioning. It inhibits the incorporation of iodine atoms into the chemical precursors, so we don't make those thyroid hormones T3, T4. It's used for hyperthyroidism and in preparation for a thyroidectomy, or the surgical removal of part or all of the thyroid. Side effects: skin rash is the biggest side effect. It can cause GI upset, joint pain. It can also cause increased BUN and creatinine, renal functions. We can also give radioactive iodine, and that is given to destroy part or all of the thyroid. If your patient is given that, they need to be careful for 7 days not to be near pregnant women or young children, because they are radioactive for 7 days. That is designed to kill part or all of the thyroid. When we do that, we commonly bring the person into a hypothyroid state. Now, hypothyroid, they're not putting out T3, T4. So what's the pituitary gland putting out? Lots of TSH, but they're not putting out T3, T4. More TSH, T3, T4. So if your thyroid is accumulating this iodine and not creating T3, T4, you develop what's known as a goiter. When you start producing T3, T4, the goiter will shrink. Some symptoms of hypothyroidism: short of breath, thinning hair, cold, weight gain, thick skin, and constipation, and depression. In fact, if you go to your doctor with depressive symptoms, one of the first things they will check is your TSH levels to see if the TSH levels are too high. If the TH level is too high, you're hypothyroid, right? In that situation, we have to simply replace the thyroxine, which is T4, with an artificial thyroxine, which we call levothyroxine. Levothyroxine, when you get on a specific dose with a specific brand, you need to stay on that brand, because different brands of levothyroxine are not bioequivalent. They will react differently in your body. Side effects are tachycardia, palpitations, dysrhythmias, and hypertension. It can cause insomnia. You'll give this medication in the morning. It can interact with oral anticoagulants, digitalis. It can cause hypoglycemia. So we want to make sure we use this very carefully with other medications. Quickly on glucocorticoids, these are produced by the adrenal glands, which sit right on top of the kidneys. These glucocorticoids specifically are medications similar to prednisone, dexamethasone, and hydrocortisone. These inhibit all stages of the inflammatory response. They're used for arthritis, allergic reaction, inflammatory bowel disease, dermatitis, asthma, and autoimmune diseases. It can also be used to actually create a reduced immune system. We want to give these, they're most commonly put out by the body in a circadian rhythm. Your body pumps them out in the early mornings between 6 and 8, and then throughout the day it drops down until it's at its low at midnight and then slowly starts building again. So we want to try to mimic the body by giving these in the morning. Now, if we're giving large doses, we may split them up into smaller doses because these can be very rough on the stomach. If you have excessive levels of glucocorticoids, either from endogenous production or exogenous, meaning artificial glucocorticoids, you could develop Cushing's disease. One of the major side effects symptoms, the moon face, a buffalo hump of fatty tissue, truncal obesity, fat around the trunk, very thin arms and legs, poor wound healing, and very thin skin. Side effects of glucocorticoids, it can actually cause temporary diabetes. So if you're being started on these, your doctor will commonly do a blood sugar check just to make sure. It can cause osteoporosis. These can cause peptic ulcer disease. We just covered that. Remember peptic ulcer disease? Hypertension, hyperlipidemia, anxiety, insomnia, depression, weight gain. Big thing is weight gain, and that's something you need to teach your patients. They need to eat food carefully because it's very easy to gain weight. You're very, very hungry when you take glucocorticoids. It can also cause poor wound healing. So we want to avoid people who have illnesses or infections. We don't want to pick an infection up. We do not stop these abruptly. This can cause adrenal crisis. Because when we're giving a lot, especially when we're giving more than 40 or 50 milligrams a day, our adrenal glands shut down because we're getting all this exogenous glucocorticoids in our system. If we suddenly stop, the adrenal glands don't start again. So we need to slowly taper off so that our adrenal glands notice, oh, we have to start producing again. Take this with food or milk to help reduce stomach upset. Assess for weight gain. Report any sore throat, fever, or weakness. That's it for the endocrine medications. Come back for the last one, analgesics.